Welcome, everyone. Thank you so much for joining us this evening for this virtual UMiami Health Talk, Gut Feelings, Medical and Nutritional IBS Management Strategies for Women. I'm medical journalist Ileana Bravo, and I'll be your moderator for this evening's webinar, which is presented by the University of Miami Health System Comprehensive Women's Health Alliance. The Alliance provides a wide range of services designed to meet the unique healthcare needs of women throughout their lives. Our comprehensive approach combines expert medical care, cutting-edge technology, and a compassionate, patient-centered environment to empower women to take control of their health and well-being. From routine exams to addressing specific health concerns, our nurse coordinators can connect you with convenient, compassionate, and expert-led care across a full spectrum of services. Please visit umiamihealth.org/allwomen to learn more about the Women's Health Alliance or to schedule a consult. Call 855-349-6636. We're going to have these numbers up again afterwards, but if you want to take a picture of your screen, you can certainly do that. As we get ready to hear tonight from two presenters. First, our founder, Dr. Morgan Sendeshu-Shane, as well as registered dietitian Monica Oslander Moreno. We will explore these topics in honor of April's National IBS Awareness Month. Some of the most common questions around the diagnosis, treatment, and management of IBS, medications and therapies, nutritional strategies, and the incidence of IBS during perimenopause and menopause. After the presentation, we'll have a Q&A session. Now, this is a unique opportunity for you to ask direct questions of our experts, so don't squander that opportunity. And all you have to do is enter them using the Q&A feature at the bottom of your Zoom screen. Take a moment to look at your device or screen and to see where that is. All right, so please join me right now to welcome our first speaker, Morgan Sendeshu-Shane, MD, a clinical assistant professor in the Division of Gastroenterology and the director of the UHealth Comprehensive Women's Health Alliance. A triple cane, Dr. Shane completed medical school, internal medicine residency, and gastroenterology fellowship at the University of Miami, as well as a master's in clinical and translational science and investigation. We're lucky that she calls Miami home and stays here. She's a clinical interest in motility and women's health with focused research in the area of pelvic floor dysfunction, IBS, as well as reflux and the microbiome. Let us welcome Dr. Shane right now, who is devoted to medical education on all levels, and she serves, by the way, as program director for the fellowship program of gastroenterology. Dr. Shane, take it away. And don't forget to unmute.
Thank you so much, Ileana. It's nice to have everyone here tonight. As it was said, I'm Dr. Morgan Sendeshu-Shane, your friendly neighborhood gastroenterologist and women's health advocate here. I'm going to talk to you a lot about IBS tonight. So when we say IBS, what do we mean? The truth is, not all changes in bowel habits are IBS. Changes in bowel habits, in fact, are quite common. They can happen for many, many reasons, including changes in your activity level, diet, new medications, and hormones, which is something we're going to touch on today. Typically, short-term changes in bowel habits can arise from recent illnesses as well as antibiotics and travel, but we're not talking about the short-term changes. We're talking about long-term changes. So what is IBS? These are the Rome 4 diagnostic criteria for irritable bowel syndrome. The Rome Foundation is basically the governing body over disorders of gut-brain interaction into which IBS falls. So you need to have recurrent abdominal pain on average at least 1 day a week in the last 3 months associated with either 2 of the 3 of the following criteria, which is either related to defecation, meaning before or after going to the bathroom, associated with a change in the frequency of your stool, and associated in change in the form of your stool. These need to happen consistently for 3 months, and it needs to happen for a total of 6 months prior to the diagnosis of IBS being made. So these are some other common, but again, not specific or diagnostic criteria, meaning you have an abnormal frequency, which could be either greater than 3 times a day or less than 3 times in a week. So already some big variability for baseline. Abnormal stool form, which we're going to talk about coming up. excessive straining during defecation, defecatory urgency, you've got to go right now, feelings of incomplete evacuation, any mucus in your bowel movements, and then the presence of other concomitant symptoms like dyspepsia, which is kind of a funny feeling in your stomach, history of migraines, fibromyalgia, interstitial cystitis, and dyspareunia, which is vaginal pain, can lend themselves further to support the diagnosis of IBS. They're not required, they're not diagnostic criteria, but they can kind of support us in the background when we're trying to arrive at a good diagnosis for you. So how do we arrive at a diagnosis? We first need to take an extensive and detailed history. First and foremost, we always rule out alarm features. Those are things like abnormal unintentional weight loss, consistent blood in your stool, fatigue, fevers, chills, sweats, lots of other symptoms that would set off alarm bells in our brain. It's not for you to decide, that's for us to decide. So you just have to come to us with your symptoms and let us sift through what may or may not be important. We then need to really characterize your symptoms. So when you come to your specialist, come with more information. What does your stool look like? How would you describe your pain? How often is it happening? These are all things that you're going to be asked in a visit. We definitely discuss diet. That's why Monica's here with us tonight to dig into that a bit further. But things like dairy, caffeine, fruits and vegetables, chewing gum can all increase or decrease or relate to your symptoms. We do a brief psychological review. Concomitant psychiatric diagnoses like depression and anxiety are extremely common in patients who also suffer with IBS. We do a physical exam. It is important to do a good quality rectal exam. We need to know if this is an anorectal disorder, if this is related to other motility problems. And then I put in big capital letters, limited laboratory studies. IBS is not a diagnosis of exclusion. We do not need to run through $1 million workup to give you the diagnosis. There are some basic important things that need to be investigated, ruling out things like celiac disease, making sure Crohn's and colitis are ruled out as well if that's a concern. But we don't really need to run through every other test looking for something tragic. A bit about menopause and GI symptoms in general before we talk about IBS specifically. 38% of postmenopausal women had self-reported altered bowel function compared to only 14% of women before menopause, which means almost 40% of women experiencing menopause have a change in their bowel habits. That does not mean that you now have IBS. We don't need to give you any new diagnoses that you don't want, but you might also have IBS, and we can talk about those things congruently and separately. Other common postmenopausal symptoms include laxative use. About 10% of women in postmenopausal age use laxatives. If you've ever walked the aisle at a pharmacy, you know that constipation is in fact extremely common because there is an entire aisle devoted to laxatives for that exact reason. Almost 50% of women experience gaseousness or excessive flatulence. And 34% also experience heartburn-related symptoms. So those are all just the glorious things that we can all experience during menopause that aren't necessarily a new diagnosis. But now let's talk about IBS and the aging women. The prevalence of IBS-type complaints peaks in about 36% of women between the ages of 40 and 49 years. So although more women are diagnosed at an earlier age with IBS, by the time we reach the 7th decade of life, the prevalence of IBS in men and women is about the same. It starts to go down once menopause is hit. Gonadal hormones, those are your estrogen and progesterone hormones. They have exert their pain sensitivity effects via a variety of mediators, including serotonin, which is the neurotransmitters that's responsible for all of the vasomotor symptoms of menopause. Those are your hot flashes. And then finally, even though we know that ovarian hormones are related to the expression of these serotonin receptors, which are responsible for pain sensation in the abdomen, we do know that replacing gonadal hormones does not result in a reduction of abdominal pain and IBS symptoms. So I think that that's important. So now that we're talking about IBS, let's talk specifically about the IBS subtypes. There's IBS-D, which is the diarrhea predominant, and IBS-C, the constipation predominant type. They're basically two opposing sides of the same coin. To have the diarrhea predominant symptom, you have to have this type 6 or 7 Bristol stool type, more than 25% of the time, and less than 25% of the time you would live in constipation land. So IBS-C, the constipation type, is essentially the reverse. Much more of the time, more than 25%, you live up here, and less than 25% of the time you live in this lower part down here. There's IBS mixed type, which is basically a completely equal variation of both types of stool. I will say that I have rarely diagnosed somebody with the mixed type IBS. I have found that most patients who oscillate between constipation and diarrhea are actually, in fact, constipated. And by treating the constipation, we prevent this kind of slamming on the gas, slamming on the brake variation, these extremes. We kind of end up much more down the middle of the road. And then the IBS-U, this untypable IBS, where patients basically just don't fit into any of the above buckets. So what are factors that trigger the onset or an exacerbation of IBS? Things that include prior gastroenteritis, so that's any sort of GI infection, viral, bacterial, food poisoning, any virus really, even the flu can kind of mess up your microbiome. Chronic stress, we know that chronic stress has been related to increased gut permeability. Basically, you as a host, your body then interacts more with bacteria in the environment than somebody who's not under chronic stress. And we do know that bacterial exposure, specifically these viral illnesses, can put you at increased risk for IBS exacerbations or diagnosis. Any prior abdominal surgery. Food intolerance is, again, we're going to dig very deep into your diet here. And then prior diverticulitis, basically any other prior colonic infection puts you at risk. IBS treatments, check out this list. This is not supposed to overwhelm you. It's supposed to overwhelm me. No, the point of this is to show you that there's a lot of treatments out there depending on the type of IBS that you have. Again, that is my job to figure out what is going on, how to get to the bottom. We have to treat the predominating symptom. That's how our guidelines are organized. They're organized to treat whatever your predominating symptom is. Is your predominating symptom diarrhea? Is it constipation, or is it abdominal pain? All of that is present in IBS, and we really focus our energy on targeting your predominating symptom, because at the end of the day, it's less important to be right. It's most important to feel better. So what can we use? What type of IBS you had kind of determines what part of the algorithm we work down. These are the prescription medications that are available for IBS-C. They all work in different methods. The first two boxes here work primarily on increasing some contraction, as well as increasing the fluid that's secreted into the intestine. Same with this last box here. This middle box here works on serotonin receptors, really targeting both the motility and the pain component in the gut. For IBS-D, the diarrhea type, we have a mix of different options, including antidiarrheals, bile acid sequestrants to increase the form of the stool. Again, something that targets both the motility and the pain, as well as here, the motility and the pain. So those are what we have available from a prescription standpoint. But there are non-prescription options as well. So yes, really, peppermint oil, believe it or not, it is actually clinically proven to be extremely beneficial in IBS for multiple reasons. You can see here that it's actually a natural smooth muscle relaxant. It modulates pain sensation. It also has direct antimicrobial and anti-inflammatory effects, and it has a stress modulation as well. Anyone who's had nighttime calm tea, there's peppermint usually in there. And the number needed to treat is 3, meaning 1 in 3 patients taking a therapeutic dose of peppermint oil have found benefit. So really low risk, high yield. Also, everyone comes talking about probiotics. It's definitely something we need to talk about. But what do we even mean when people say, should I be even having probiotics? Probiotics are the live microorganisms that are consumed in your diet intended to maintain or improve the normal flora in your gut. Basically, they're the good bacteria that live in your body. We are made up of more bacterial cells than human cells, and we need the good bacteria to keep the traffic moving inside our body. So foods, this includes yogurt, kefir, sauerkraut, tempeh, basically anything that's naturally pickled or fermented. We highly, highly recommend a diet rich in probiotic foods. we don't really recommend probiotic supplements. If you're committed to a supplement and you tell me that this probiotic has changed your life, of course, I'm not going to tell you to stop it. But frankly, the data doesn't support probiotic supplements for many reasons. One, they're not personalized. Two, you ingest them, you eat them, and they go straight into your stomach. Your stomach's entire job is to keep you from getting sick by killing the bacteria that you ingest with stomach acid. Much of these supplements die before they even have a chance to set up shop in your small intestine, which is where they really need to do their work. And some data even show that in patients with known constipation, probiotic supplements can lead to brain fog and bloating. Again, if you're committed to your supplement and you enjoy it, by no means do you need to stop it, but we don't recommend starting it. We do recommend foods that are naturally rich in probiotics. We also recommend a diet that's naturally rich in prebiotics. What are prebiotics? Basically, the food for the bacteria. These are fiber that help to promote a good and varied bacterial microbiome in your intestine. So these are garlics, onions, leeks, asparagus, bananas, cocoa. You're all welcome for that, by the way. And lots of other foods. So working with somebody who can really dig into your diet can help you mitigate your IBS symptoms, which is where our teamwork with our dietitians really comes in. So some takeaways here. Changes in bowel habits can be normal and not everything is IBS. However, IBS is a real diagnosis that has real criteria. You don't need to figure this out on your own. That's my job. You need to see a specialist where we can help you identify what symptoms and most importantly, help you feel better. And it's important to treat the predominating symptom. Medications can be used to help improve IBS symptoms, but it is also really important to take a very deep dig into your diet and lifestyle to see where we can make changes that play a major role in our overall management.
That was great. And yes, I took away cocoa. I can have chocolate.
All the hot chocolate you want.
I'm sure you're going to explain a little bit further as to just moderation and everything. But thanks so much. As usual, you're so clear and everything you say is just easily understood. So let's tee up our next speaker, Monica Auslander Moreno, MS, RDN, founder of a group practice of registered dietitians and psychotherapist in Miami. Monica oversees her private client work while focusing on corporate wellness programming, speaking engagements, non-private client nutrition consulting, and school wellness programming. She was the Miami Marlins dietitian and is the visiting dietitian specialist at Ocean Reef Resort and Club. Monica is an adjunct professor in the graduate dietetics and nutrition program at FIU and formerly was at both Kaiser University and the University of Miami. Let's welcome Monica, and let's remember all of you who are registered tonight and who are on this talk with us, please ask your questions. We are anxious to start a good discussion here tonight. So Monica, it's all yours.
Thank you so much. Hi, everyone. I'd like to thank the University of Miami Women's Health Alliance, Dr. Shane, and her fantastic support staff for having me this evening. I apologize for any audible or visible intrusion of creatures in this webinar, as it is the Bed Bath & Beyond hour and anything could happen. So I've outlined a few key points here in my spiel, but fear not, we will be leaving time for that Q&A that we've been mentioning, as I know there are many topics beyond what I'm going to touch on here that are of interest. And of course, if we bid farewell and do not get to speak, you are welcome to reach out to me after this presentation via email for a session or any other questions. So Dr. Shane and I tried to pull together some common realities of IBS that we see in practice. One of these that comes up all the time and has already come up in this particular webinar is the question of FODMAPs. They have been a hot dietary protocol since actually Dr. Abreu, if those of you are familiar with her, you're very lucky, introduced them to me in 2013 when I was a wee dietetic intern at the Crohn's and Colitis Center at University of Miami. And it even deeply saddened me to bid farewell to things like pears and watermelon for my own health, but I was convinced clinically even then that this works, this dietary protocol works for IBS. But let's define what it means for a dietary intervention to, quote, work. So first things first, FODMAPs is not meant to cure your IBS. Dr. Shane just showed you a beautiful laundry list of medications and therapies and things to help with your IBS. Food didn't cause it, so food's not going to cure it.
Monica, if I can interrupt you real quickly, you need to start your presentation.
Oh, is it? Oh my gosh, I'm so sorry. I
Okay,
did not
that's
share
all
my
right.
screen. Goodness me.
We
Okay.
love seeing you. We love hearing the info, but let's see it on the screen as well.
Okay. Well, now you can follow along with me, Sesame
Correct.
Street style. All right. Okay. Now you see our FODMAP realities. Okay. Time to get real. It's like the real world. So FODMAPs are not meant to cure your IBS because IBS is a syndrome. It is a group of diseases. Your IBS is different than my IBS, etc. FODMAP dietary interventions will probably, based on research and clinical experience, result in some degree of symptom remediation for you if you are honest with it, which is very hard and very terrible for some people, including myself, and realize its intentions and limits. So again, food didn't cause your IBS, so it's not the whole story of the cure or the management, we should say. Now, for those of you unfamiliar with it, this is my job to explain to you. It is a temporary and intentional and meticulous protocol designed to reduce or eliminate what are called FODMAPs. What are they? I'm going to make you say them 10 times fast. Fermentable oligosaccharides, saccharides, monosaccharides, and polyols. I'm joking. So that's why we have an abbreviation for it. They are certain types of carbohydrates to then allow us to reintroduce these types of carbohydrates, which are actually fibers. Fiber is a carbohydrate. And basically, once we introduce them back into your intake, we see who kind of misbehaves, who's causing IBS symptoms, and we kind of pull back on those. So why is this like a thing? What are these FODMAPs? Why are they so bad? So carbohydrates are absorbed in our small intestine, and what's left is incompletely absorbed and then taken on down to our colon to produce what are called short-chain fatty acids, and then out they go. These are known as prebiotic fibers. Dr. Shane talked about things like Jerusalem artichokes and, chocolate. That's what I saw in capital letters. However, these are really healthy things. And here's where it gets kind of, murky, is that the wrong type of too much of a good thing in people with IBS can cause bloating and discomfort. So if you go out and eat a bunch of quinoa, which this happens to me because it's so healthy and wonderful and expensive, you're going to maybe have symptoms. And so these are the foods that are the common perpetrators, and they are called the FODMAPs. So here you are, and you've got your little nifty handout, and you say to yourself, I'm going to do the FODMAPs diet, and then it doesn't work. So why does that mean? You still don't feel like Snow White traipsing through the forest. You have all of these gut symptoms. But as Dr. Shane has always said to me, why do you expect that you're going to feel good all the time? You have IBS. And unfortunately, it's because this there's a wellness industry sells you a fallacy, but the reality is that even people without IBS don't feel amazing all of the time. And those of us with IBS have that hypersensitivity and pain issue and visceral hypersensitivity that she mentioned. So why do we think that we're going to feel amazing, if we just cut out, for example, some pears? We won't, because IBS is complicated. So where do we find FODMAPs? We find them in plant-based products, and hence following a strict low FODMAP diet with a staggered reintroduction may be very difficult because plants are everywhere and we need them. And this is because true adherence to a FODMAP protocol pretty much means you don't dine out for various weeks at a time, because restaurants and takeout and your friend's house that they're cooking for you are probably cooking with things like butter, garlic, and onion, and other FODMAP-y little sneaks like a lot of spices. So fine, you decide to recede into a cave for 6 weeks, and then you buy $400 worth of FODMAP-friendly processed stuff online. No, because processed foods, meaning foods like bars and proteins and powders and potions marketed as low FODMAP, may not be appropriate for your FODMAP protocol. And that's why it's quite important to work with a dietitian. There's just no way around it. I wish I could just tell you to use one of the wonderful apps out there and send you on your way. Okay, and then, all right, you're still taking 100 vitamins and supplements, but even those can harbor FODMAPs. And then you get real comfortable and feel great because, okay, 6 weeks later, we've got you just straight up eating white potatoes and grilled chicken and white rice. And of course, that feels great, but it's not nutritionally adequate, realistic, and you need diverse fibers in your diet for optimal microbiome health, like Dr. Shane talked about. We do need some prebiotic fibers. So the goal of FODMAPs is not to actually take away. The goal is to liberalize as much as possible without letting in, the FODMAPs that are going to misbehave. And for me, that's pear and peaches. So you do have to learn a little bit by some empirical learning. And unfortunately, it's kind of a sticky and long process. That's just the way it is right now. It can be bland, it can be boring, And I basically only do it with people, you know, who really can commit to the process and choose to take some measured risks for the sake of living their lives. But I do like to work with each client individually to determine their ultimate goal as far as symptomology reduction, quality of life, commitment to the protocol, and, you know, how far they're willing to go as far as elimination and then systematic reintroduction. Okay, so this is not a FODMAP lecture. We are moving on, but perhaps we'll do one in the future. Another thing that Dr. Shane and I love to toss around a lot is talking about lactose. And if anyone knows me, they know that I love cheese because it is my favorite FODMAP and cheese is my love language. We have so many clients who really don't kind of like need to ruin their entire lives by doing a full-on FODMAP protocol, but are downright suffering because they're simply lactose intolerant. So this likely will be all of us one day because lactose intolerance occurs in a lot of people from, you know, it's just a genetic human predisposition. What is lactose? Lactose is the sugar that is found exclusively in mammalian milk and is digested by the enzyme lactase in the brush borders of the intestine. Now, if you don't have enough lactase, you're not going to absorb lactose very well. This unabsorbed lactose is just wandering around in your intestines and produces gas, diarrhea, bloating, and flatulence. Unpleasant. Now, this is unfortunate because a lot of people actually are lactose intolerant and don't have symptoms and don't even know until they know. And you'll know when you have it, unless you're like my husband who denied it for 10 years and then decided to kind of fess up. That is a story for a different day. Most people with a primary lactase deficiency, which is classic lactose intolerance, can actually have some amount of lactose, and then there's a threshold. So it may help if you think you're lactose intolerant to talk to Dr. Shane, and you may need to divide your daily lactose doses into several small portions or have it with other foods. Now, secondary lactose intolerance is something different. That often occurs after one of those gastrointestinal illnesses that can then lead to some kind of IBS-like syndrome. Dr. Shane has recommended that I abstain from lactose from 2 to 6 weeks after my children always give me norovirus, and I laugh at her and then I suffer because I don't always follow the advice that I give. So practically, I would rather people with lactose intolerance just avoid lactose altogether, but that doesn't mean avoid dairy, because then you're missing out on some really great sources of protein, calcium, vitamin D, and potentially probiotics. Shout out to kefir. You also cannot be allergic to lactose because it is a carbohydrate. Food allergies typically come in the form of protein allergies. So lactose is a FODMAP. You can be allergic to proteins in cow's milk, but you are much more likely, because people come in saying, I'm allergic to milk. And I'm like, you know, epidemiologically, that's quite rare. You are much more likely to be lactose intolerant. So people then eat at restaurants and suffer, even though they're saying, I'm not ordering pizza, I'm not ordering cheese, what's going on? And that's because restaurants love butter, and butter has lactose. And dairy-free on a label or on a menu doesn't mean lactose-free. And then there's these like wild myths out there about low lactose products like cheese and goat cheese and sheep cheese. And yes, they're lower in lactose than, say, cow's milk. But if you've got a really low lactose threshold, every gram counts. So that's not going to feel good to you. So I would advise you to get to know your own body and threshold and perhaps work with a dietitian. Admit your lactase enzyme has gone extinct, and, you know, perhaps with my ability to stay up past 10 p.m. Another fan favorite that people like to vilify is gluten. This is a really great scene from a Seth Rogen movie about gluten. I find it very funny. There's just a lot of misinformation out there about gluten, and we've felt it deserves some time in the IBS spotlight. But what it does not deserve is a complete vilification. It is not bad for you, you know, unless, ... we will discuss. Although it can mess with your intestinal villi if you do have celiacs, and that is a dietitian pun, and I do not apologize. So gluten is just one of the proteins found in wheat, barley, rye, and although oats technically do not contain gluten in their structures, they are commonly cross-contacted with them. And there basically ends the story of gluten. Unless you have celiac disease, which is an autoimmune disorder in which your body begins to attack itself in the presence of gluten, this is actually quite rare in my practice, the rest of people who eliminate gluten are likely just intolerant to it as a FODMAP, or the foods that you're eating coincidentally contain gluten, which might make anyone feel yucky. Some of these foods are things like super processed protein bars and a bunch of cookies and processed fast food breads, and then people go gluten-free and they feel better. So my question was, is it the FODMAP or is it the company that the gluten-y FODMAP kept that was making you feel yucky? So, and then we have folks who eliminate gluten for whatever reason, social media reasons, and then they're still bloated because gluten-free products can still mean this is going to make you quite bloated because of other bloaty or FODMAP-y ingredients. And then we do have people who actually would benefit from eliminating gluten because they're intolerant to fructans, which is the FODMAP in it. And gluten is real sneaky, and it even exists in microscopic amounts on surfaces where it cannot be seen by the eye. So if you took a bun off a burger, that burger would still have gluten contact on it. Yikes. So being a dietitian is like playing a crazy video game where like every step you take, there's like a snapping crocodile and you're playing whack-a-mole with it. So now you know about lactose and gluten, and here we are thinking people going dairy and gluten-free are feeling better. Are they just FODMAP intolerant? Do they have IBS? I don't know. I'm like this emoji, but Dr. Shane has to diagnose them, and I am here to guide them towards a wiser path of relief. And in my remaining time, I'd like to talk about protein. So, and bioavailability of nutrients with regarding protein. So put down your almond milk latte, because also if you're drinking one at 6 p.m., you must be a doctor or a mom, because we're going to discuss the protein digestibility amino acid score. It's a party trick to say it fast. This is, as you can see, a very lovely scale. We'll regrade proteins as far as how great they are at getting into our body and being absorbed. And that means it's basically what their true fecal nitrogen and ileal digestibility is. So all dairy proteins, including casein and whey, which you might have heard of, have like a near perfect 1.0, like Simone Biles 1.10, you know, as far as protein goes. And fun fact, things like nuts and almonds have a higher PDCAAS score, but nowhere near milk, okay? So they're not actually a great source of protein when we compare them to dairy proteins. Basically, whey, which is the predominant protein in milk and dairy products, is a really well-absorbed bioavailable protein. But whey is not lactose, so it is not a FODMAP. It is a protein, and lactose is a carbohydrate. So it would be quite sad to eliminate whey if you really did not have to. So even if you do have IBS, unless you have a milk protein allergy, you probably don't need to be eliminating the most wonderful world of whey. And this is particularly salient advice for women, because we know that whey protein is an amazing protein for bone health and muscle mass maintenance. And as women, we are losing muscle mass, like I lose patience with my children, and whey can help us maintain and grow muscle so we don't end up with osteoporotic diseases and we have nice Pilates posture. So whey protein powder is lactose free, so is most kefir. And for people who can't do lactose, we can do lactose free milk. And my next choice would actually be unsweetened soy milk based on the PDCAAS. It's like nearly perfect, like my former dog. Almond milk would be like my 17th choice because its protein digestibility is like wah, 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 all the way down here. And almond milk, I don't particularly think is terribly delicious. All right. Other things that kind of give me pause. Emulsifiers, preservatives, and gums. Oh my. Now, some of these little demons may be categorized as FODMAPs just from their carbohydrate origins, and some are just very likely to cause GI symptoms of all sorts, especially in clients and patients with IBS. I cannot even go near soy lecithin, and it's in all of my favorite chocolates. So these things are stuff we add to food for various reasons. The FDA has recognized approximately 450 of them, and we got a lot of these floating around the food supply. What you can do is to read labels like this. This happens to be Nutella, which is delicious, and just stay conscious of them. And if they happen to trigger you, they're typically found in what we call processed foods. And I use these quotes because foods like yogurt and hummus are processed, but it doesn't mean that they are bad or unhealthy. There's no binary, when it comes to nutrition. That's for another day. But these things might be contributing to your IBS symptomology, and maybe doing all these things we see on the right, which will not, be very, very pleasant for you. They're very hard to avoid, all of these emulsifiers, etc. Again, me and my lecithins, and you might be completely fine with this stuff. You might not suffer when you intake them, and that's great, but you might suffer with other types of FODMAPs. I don't know. And that's kind of why we have to work really closely together to determine what the safe foods are and the not safe foods and additives are, okay? Our final slide will be the fiber slide, and I will never stop with puns. So lots of clients come to us feeling really bloaty, water balloon bloaty, because they're like, oh, I have IBS. I'm just going to add a lot of fiber on here. Fiber is the panacea. And wellness influencers are selling prebiotic fibers, which are super FODMAPy, like inulin, Fiber One cereals, fiber bars, fiber, it's raining fiber. And I'm shuddering because as a dietitian, I do love fiber, but when it's consumed in the form of a low FODMAP fruit for someone with IBS, not a fiber bar, not fiber crackers, and of course, nothing that will send your IBS into a dark abyss of pain. So we don't want to just go loading up on fiber. You're going to need to get to know your particular IBS subtype. We've already been over that, or your IBS mimicking disease with, a GI like Dr. Shane, because your IBS or whatever condition you have may have absolutely nothing to do with fiber. And this, if anyone is interested, is my case. And really, it's a very deflating truth to face because you can't just salad your way out of this problem. And in fact, too much or inappropriate types of fibers can really make things worse for your IBS because your poor colonic bacteria then has to deal with all that fiber. Because fiber is technically indigestible, which is part of the reason it's so great for our bodies, but that's a heavy burden and that's a heavy cross to bear because wellness influencers are like, eat 17 fruits and vegetables a day and all of the quinoa, and that just can be a really bad idea for many people with IBS. But what if your fiber or your IBS is fiber related in some way? Well, FODMAP protocols have a lot to do with fiber. We can certainly make sure you're getting enough and varied and adequate fibers within your IBS and FODMAP protocol. And there's an app for that, and there's a person for that, and that person is me. Hooray. Or perhaps we need to pace your fiber throughout the day. We need to discuss not what I call FODMAP layering, which is like eating a bunch of low FODMAP foods at one time that can then become high FODMAP. We have to discuss fluid intake, movement, sleep, stress management, probiotic sources you can tolerate, like Dr. Shane had mentioned. We need to discuss soluble and insoluble fibers, an ideal amount for you per day. We've got a lot to talk about. And this is an ideal amount of talking for me right now. So I will end this here and we can move to some Q&A.
That is wonderful. Thank you so much, Monica. And yes, we are ready for the Q&A, but I've taken a couple of quotes from you too. First of all, you can't salad your way out of this. So that freaks me out because we all think, oh, I'm just going to eat a lot of fiber and salad and I'm going to be just fine. Secondly, almond milk is not great.
I ruin everything. I'm like the Grim Reaper. No, I'm kidding. But yeah, this is why I decided to include those points, because this is very common that, I'm just going to load up on fiber and vegetables and, food is medicine. And no, medicine is medicine. Food is food and it's really wonderful. But you might be contributing to the problem nutritionally if you're, throwing pasta at the wall, so to speak.
Right. So one of the questions that came through is, what are good probiotics and prebiotics that are not dairy? So that's where the almond milk question came in, and that are, non-dairy, and also like broccoli and cabbage and things like that are so gassy. And then we're going to move on to Dr. Shane for a moment, but Monica.
Okay, so we still have non-dairy sources of, well, remember, my first question is it lactose or is it the milk protein that we're, doing here? So there is something called miso, which is a fermented soy product, and tempeh. You might have heard of miso soup. Tempeh is a fermented, like a tofu. It is a soy protein. It tastes absolutely delicious when you cook it up appropriately. Otherwise, plain, it could be a little unpalatable. Sauerkraut and pickled things are also really wonderful sources of non-dairy probiotics. But as Dr. Shane has taught me, if pickles have vinegar on the ingredient list, they've actually kind of been flash pickled and they don't have those yummy good bugs in them that contribute to microbiome health. They still are delicious in a form of vegetables, but you're not getting all the bangs for your bug, so to speak.
Okay. All right. All right. Let's talk, Dr. Shane, let's talk about a question that someone posed, which I found very interesting. She says, IBS gets worse after menopause. So is IBS an aging disease?
So no, not really. It doesn't mean that as you get older, you can't develop something new. I mean, I think everybody recognizes, my favorite phrase to tell people is that used to doesn't live here anymore. Just because you used to not have something or used to be able to tolerate a food doesn't mean that that is your current condition. But it's really critical to kind of look at all your symptoms. As we age, we need to rule out things that are more alarm features. So certainly the older you are with new GI symptoms, that is something that needs to be addressed in clinic with a physician as soon as possible. But IBS actually goes down after the age of about 50. The prevalence, meaning how many people live with IBS, actually goes down. It doesn't mean you can't get it after 50. It's just much less common than it is before the age of 50.
Dr. Shane, does IBS lead to colon cancer?
What a wonderful question. No, it does not. IBS is a disorder of gut-brain interaction, meaning how your brain and your body feel. And the same neurotransmitters that work in our brain, the dopamine and the serotonin that help to control our mood, our anxiety, depression, our excitement, are the same neurotransmitters that work on the motility of the gut. But there is no risk of cancer with irritable bowel syndrome. That doesn't mean that you can't be someone who has IBS and develop colon cancer, but they're unrelated. Other gastrointestinal diseases like IBD, inflammatory bowel disease, that's Crohn's and colitis, that can carry an increased risk of malignancy with the chronicity of the disease, but irritable bowel syndrome does not lead to cancer.
And now let's go to, how about diverticulosis and those other inflammatory diseases of the bowel?
Great question. So diverticulosis is a completely benign, often age-related disease of the colon, which is just a structural disease. These are small outpouchings in the wall of the colon, little balloon exaggerations of the wall of the colon that happen as we age and are more common in people who have a genetic predisposition to them, as well as chronic constipation. But diverticulitis is the inflammatory component. Not everyone with diverticulosis develops diverticulitis, but diverticulitis is inflammation and infection of one of these little outpouchings as a result of bacteria that usually get stuck in there from stool that hasn't cleared. So patients with recurrent diverticulitis may experience IBS and IBS type symptoms as a result of frequent infection and frequent antibiotics if they are prescribed for diverticulitis. Not all diverticulitis episodes require antibiotics, separate conversation, but it certainly can increase your risk for developing IBS, especially in patients who experience this in younger years.
And just for everyone to be on the same page, things like diverticulosis and conditions like that are picked up in a colonoscopy. So once you have that, let's say your baseline colonoscopy at 45 and you have it now, you know that you might be at a little higher risk. Instead of waiting the 10 years, you do it in 5 years, right?
Yeah, definitely certain things will increase your frequency of colon cancer screening. That's what colonoscopies are for. They can be used, of course, to diagnose other disease processes, but we don't routinely screen people with IBS. They're not at increased risk of anything specific that would require a colonoscopy. Just because you carry the diagnosis of IBS doesn't mean you need a more frequent procedure. But certain other underlying GI disorders may increase your frequency. So that's why you have to work with your specialist.
Okay, so let's go over to Monica. How about pregnancy and IBS and managing it with diet modifications?
Oh me, oh my. Yeah, I think Dr. Shane put it best in, as I'm reading, pregnancy changes all kinds of symptoms. Yes. So most women do, I would say, experience some GI symptomology during pregnancy, some of which fall under the IBS category. Typically that results in constipation, which if you've had IBS-D your whole life is actually kind of nice, but not to minimize it. This is what happened to me if anyone is interested. But there are definitely, things you could institute a low FODMAP protocol. And of course we would share your decision-making process, with the client who already has a lot going on being pregnant. Versus safe and effective medications that can help you have a very happy daily bowel movement experience. And I would leave that to Dr. Shane. Diet-wise in pregnancy, there's no contraindication to any of the probiotic foods except kombucha, because it can be raw and unpasteurized and contain some alcohol, which is not safe during pregnancy. And as always, for anyone pregnant, we want everything to be pasteurized. So some of the pickled vegetables and things that you get at like farmers markets, I wouldn't be comfortable with. I'd rather get them from, a brand that's a little more regulated and there's temp controls and things like that. But typically IBS-C does flare up during pregnancy, although in the beginning stages, we do see a lot of IBS-D. So it's really person specific, and we kind of have to discuss how to manage, what kind of day and what kind of symptomology you're having and how to tailor your foods that day to that particular symptomology.
Monica, just from the Q&A box, I'm seeing a lot of people saying basically how their IBS or their gastroenterology conditions are uncontrolled. Are we just not eating right? Are we not, do we
Everyone
not know
plays
what
the
we're supposed
food.
to
I don't think it's fair. I think as a nation, our IBS, what causes IBS? Dr. Shane, yes, we can, there are definitely associations in research between things like ultra processed food and IBS, but is it chicken or egg? Which came first? Which came second? I like to also place some blame on our mental health and our pelvic floor health and our lack of sleep and movement as well as the realm of nutrition. And I think that IBS, like many human diseases, is something that we need to approach from a very spherical vantage point and not just look at the food and expect the food to do everything for us.
Dr. Shane, a question just came over about gallbladder issues and their role in IBS.
Great question. So gallbladder issues are not directly linked to IBS. Gallbladder issues, specifically things like biliary colic, that feeling of right upper quadrant discomfort, especially after eating within 20 to 30 minutes of eating a meal, especially a fatty meal, that's its own entity. That is not IBS. We do know that some people who get their gallbladders out can develop post-cholecystectomy diarrhea, which is related to bile salts and an excess of bile salts that were previously stored in your gallbladder that are no longer have a home because you had your gallbladder removed. So they end up being secreted directly into your GI tract, and they can cause diarrhea, which is why using bile acid sequestrants can be beneficial in terms of especially increasing the form and and decreasing the frequency of patients who experience IBSD. But that's its own thing. It's not necessarily IBS. It's its own entity. It's bile acid diarrhea. Right upper quadrant train from biliary colic is biliary colic. IBS really has its own diagnostic criteria based on those Rome Foundation recommendations.
All right, so we know that perimenopause and menopause puts us at higher risk of IBS. A question on how about when you're a menstruating woman, how about if you have irregular cycles, irregular periods? Is that a risk factor?
It's a wonderful question. Hormones, especially estrogen and progesterone, cause a variation in the motility of your gut. We know that. That's why it is actually normal to have variation in your bowel habits when you menstruate. When you are at the peak of your ovulation, when your estrogen peaks, it's actually normal to get a bit constipated. And while you're having your menstruation, it's a pretty normal actually to have loose stools and even some cramping. That is all normal female physiology. The same thing holds true to what Monica was mentioning before about pregnancy. It's pretty common to become constipated in pregnancy, mostly because of this huge surge in progesterone that we see. But that's not really IBS. IBS has its own set of symptoms that aren't really blamed on other things. So you can experience changes in your gut motility with menopause, with your cycle, with irregular periods. Obviously, the longer your cycle is, the more symptoms you may have related to diarrhea. The more infrequent your cycle is, you may actually have more constipation as a result of higher estrogen, but that's not necessarily IBS. IBS has its own criteria, and you really need to work with your gastroenterologist to make sure you have the right diagnosis and that we're not missing something else like endometriosis or another concomitant disease that may be a confounder.
There are just so many questions. I'm just monitoring the Q&A box, which you ladies can too. Is IBS causing my cystitis?
So they're common together. I always like to say that interstitial cystitis is like the IBS of the bladder. It kind of has the same phenomenon. There's increased pain, increased frequency, changes in all kinds of things. And so it's more common to get interstitial cystitis in patients who have IBS, but the two diseases in and of themselves are not related. You don't need one to have the other or vice versa.
How about acid reflux? This question just came over as well. How about acid reflux leading to IBS?
Nope, it's its own problem. You can have both things. You can have acid reflux, you can have IBS. Many of the things you're eating may be contributing to both. Monica can certainly attest to that. But no, they're separate problems. IBS has to do explicitly with your bowel habits.
Mm-hmm. And so Monica, yeah, I mean, here's questions on lactate pills and all sorts of medication that people are taking to control their discomfort, I guess.
I actually was gonna ping that for you, Dr. Shane. Can you touch upon lactate pills? Someone asked how many or how often, and I was like, ooh, here she goes.
Sure. I have feelings about lactate pills.
She has gut
Basically,
feelings about lactate pills.
they fall into the same bucket as probiotics and supplements. The lactate pills, lactate is the brand name for the enzyme lactase, which is the enzyme in the brush border, as Monica mentioned, of our small intestine that breaks down the sugar in milk, lactose. Lactase is a protein. Enzymes are made of proteins. Your stomach's entire job is to break down proteins. So what happens when you eat lactate pills? They get digested almost immediately by the hydrochloric acid in your stomach. So lactate pills, you may see a mild benefit, but overall, they are not the cure-all for lactose intolerance. The only real management for lactose intolerance is abstaining from lactose in your diet. And lactose is sneaky. It's not just the obvious things like the milk, cheese, and ice cream. It's the cream cheese, the sour cream, the baked goods, croissants. The reason why they're so flaky is because they have butter in between each layer. So just because you can't see the lactose doesn't mean it's not there, which is why it becomes difficult to pinpoint what in your diet is causing your symptoms, which is why you need to work with a professional, a GI and a dietitian, to really dig into your dietary habits and see where we can make interventions that aren't gigantic sweeping removals of food from your diet.
Both of you, please weigh in on this chocolate thing. Is indeed chocolate good for you? I'm well aware. I like dark chocolate. I know that's better for me, right? The higher content of the cocoa, right? Is that true? Is that the way I should be eating it? Of course,
Well, Dr. Shane came to my nth birthday party last year, which was at a local chocolate shop, because I became a level 2 certified chocolate taster, because that is how strongly I feel about this question. Cacao, which is the plant derivative that grows, on trees, is has many powerful antioxidants and polyphenols within it. It does have fiber. It is a prebiotic fiber. It can, in some people, be an IBS trigger, although that's, very person dependent. Was there a question, or am I just thinking about chocolate now?
Yeah, I think you are. And I want to apply for that job that you're doing, the chocolate tasting.
Yeah, I still have one more level to do, but I actually have to go into
from a GI standpoint.
Yeah,
chocolate is a mixed bag because it has these great things, these prebiotics like cacao, which are really beneficial in terms of helping to promote good gut microbiome health. However, chocolate is rarely unadulterated, which means
not just cacao.
Has milk in it, milk chocolate. There's also often soy lecithin, which is an emulsifier that can be difficult to tolerate. And chocolate has caffeine in it, which can cause smooth muscle relaxation and lead to increased reflux in some patients. So there's nothing that's just like perfect, unfortunately, out there. Everything comes with its pluses and minuses. But if you like chocolate and you tolerate it well, specifically dark chocolate, it is a great addition to your diet. It's fantastic for your microbiome. It just you need to make sure it doesn't come with all the other garbage that often comes in packaged and processed foods.
And that's what I meant to say, cacao, not cocoa.
Yeah, it's great stuff.
I got that wrong. But but the other question that I'm sure is on a lot of people's minds, since everyone likes their little cocktail and their wine, how bad is that for all of this that we're discussing?
I always tell I'm sure Dr. Shane can opine, I always say alcohol is a gastrointestinal irritant, no matter how you slice it, even if it's low FODMAP liqueurs or alcohols versus high FODMAP ones. It also is the company that it keeps, what you're putting in your cocktail. It also is how many you're having. It also has to do with if you're having it with food, if you're hydrated enough, the gut brain axis and mental state you're in when you drink it. It's not a health food. It's not something I recommend, as far as, in health enhancement. That said, it can be included mindfully and judiciously and legally in a lifestyle.
Mm-hmm.
It may or may not trigger someone's IBS symptoms, among other things. Dr. Shane, how do you feel about?
Yeah, Dr. Shane.
Yeah, I think that I hate to make generalized sweeping recommendations, right? That's why you really need to come and see your friendly neighborhood gastroenterologist and your dietitian and your primary care doctor. I can't stress enough the importance of seeing a primary care doctor, someone who's going to be that quarterback for you for many things that you have in your health. But everybody tolerates things differently. If you're somebody who has no symptoms related to alcohol, then by all means, consume it responsibly in the appropriate amount that's recommended, which is about 1 drink per day for women. But if you are somebody who has many symptoms, that may be something in your diet that you need to look at. Maybe we need to look at how frequently you're consuming alcohol. With what are you consuming the alcohol? Maybe it's not just the alcohol. Maybe it's whatever mixer that you're mixing with it. Lots of things are, unfortunately, good luck finding a cranberry juice, for example, that's not, 94% sugar. And so there are lots of things that are constantly co-ingested, so everything's a little bit confounded, and you really need somebody to help you demystify these things. Many people can't tolerate alcohol. It is very common cause of loose stool in most people. But if it's not bothering you, then don't worry about it. It only matters any of these things only really matter if they bother you.
Well, ladies, unfortunately, we're going to have to wrap things up. I thank you for this wonderful conversation. I think a lot of people learned. There are still a lot of people hanging on, waiting to get more information. So this is the time for us to drive them, to thank the audience for being here, to drive them right to the website, umiamihealth.org/allwomen. And you're going to connect with the Comprehensive Women's Health Alliance at UHealth. Please call 855-349-6636 if you want a consultation and want to talk to these wonderful professionals who are leading the charge here to give us women a better quality of life, to make sure that we are looking at every aspect of our health and lifestyle. So thank you again to our experts. Bravo to all of you. And please hang in there with us. To the audience, please finish the survey at the end to let us know how we did. And we wish you all a wonderful night. And everyone, please stay safe out there. We'll talk to you another time.